I think community physicians need to know that now we have in the United States 4 approved options for myelofibrosis. And with this, one, who does not need to be on medical therapy now? I think that number is vanishingly small. Truly, the very low risk, completely asymptomatic patient without significant cytopenias may still be able to be observed. And again, this is a small number, but I think that it still remains very reasonable. 2, we're always evaluate the potential role of transplant. So a good baseline workup, including molecular testing to assess their risk score by MIPSS 70 or some equivalent, an appropriate referral for consideration of transplant for those that are higher risk that have a donor. That being said, JAK inhibitors, we now have 4 agents. Ruxolitinib that people are well familiar with. Ruxolitinib and Fedratinib can be used in the frontline or second line setting, are particularly helpful when we don't have significant cytopenias, and Rux and Fedratinib by the NCCN guidelines can be considered almost interchangeably. In terms of, now we have Momelotinib and Pacritinib. Momelotinib indicated for MF with anemia. That can be anemia in the frontline setting or the second line setting. And clearly, the more significant the anemia, the greater the case for considering Momelotinib. And secondly, Pacritinib, which is approved for a platelet count of less than 50,000. And certainly there's data for consideration for platelets between 50 and 100,000. So 1, we have 4 options. 2, if a patient isn't responding, consider one of the backup options. 3, the cytopenias are probably the single biggest component of helping to differentiate which JAK inhibitor to use in which setting.